Today's webinar is dedicated to nursing work worldwide and focused on working in disaster. I am proud to introduce our four presenters, Teresa Green, Vicky Treacy-Wong, Melissa Hozjan, and Corinne Heaume. Our presenters have vast experience in the humanitarian field, providing nursing care in disaster and conflict area, dealing with public health, epidemiology, emergency nursing, pediatric nursing, tropical medicine, infection control, global health and quality improvement, as well as nursing leadership. Colleagues, the floor is yours.
Thank you, and welcome everybody. My name is Vicky, and I am proud to lead the nurses in MSF. So welcome to our reflections of nursing in disasters. Next slide, please, Corinne. So on the panel today, you've got myself. I first joined MSF in 2005. And I worked for 3 years. I then rejoined in 2012, and I've been the nursing advisor for OCA since 2016, and I've worked across countries in Asia and Africa. Next up is Melissa, who joined MSF in 2011. She's completed over 13 field assignments, and she's now the pediatric nursing care advisor since 2018. Corinne has been with MSF for 3 years, and she's been working in refugee camps in Thailand and conflict in Central African Republic. And Maria, she joined MSF in 2010. She's worked as a nurse manager and project medical referent, and has also worked in many epidemics like Ebola, yellow fever, as well as conflict and malnutrition. It's a real pleasure for us to join you this evening. We're really aware that WEDM was founded in 1976, so it really has had a long history. And we're also aware that you have really strong nursing leadership. So it's been a real privilege for us to be invited and to share our reflections with you. I'm going to now hand over to Melissa, who's going to take us through where MSF works and to introduce us to our nursing workforce. Over to Melissa.
Thanks, Vicky. So Médecins Sans Frontières, we are an international medical humanitarian organization founded in 1971. You may have heard us referred to as Doctors Without Borders or simply as MSF. We provide healthcare in complex humanitarian settings to everyone who needs, irrespective of race, religion, creed, or political convictions. Our actions are guided by medical ethics and the principles of impartiality, independence, and neutrality. And these are particularly important working in disasters where an urgent response is often needed. Our independence allows us the means to act when, where, and how we see we can have the most impact. More than 95% of our funding comes from private donors, with 85% of donations directly supporting our social mission, our activity on the ground. Our activity is delivered where it is needed most, such as in armed conflicts, epidemics, famines, and natural disasters. Following a disaster, restoring basic health services is vital to avoid illness and death overall, particularly for vulnerable populations such as women, children, and newborns. People who are displaced and those with pre-existing needs still need care, and the risk of disease outbreaks are heightened. We also have projects that focus on maternal and child health, for example, non-communicable diseases, infectious diseases, HIV, tuberculosis, surgical activity, and health promotion. These may be delivered in an inpatient setting, such as a hospital, in outpatient in mobile clinics, at home, or in search and rescue boats in the Mediterranean. We also work to raise awareness for global populations and on behalf of the populations that we assist. In the 50 years since being founded, MSF now has over 450 projects in over 70 countries around the world. This map here indicates some of the countries we work, but in fact, the map is a little bit outdated. It was pre-COVID. So we have since provided support in many countries where we previously had not worked, such as in the United States and in several European countries, including in France and in Belgium. Our teams are made up of tens of thousands of health professionals, logistics, and administrative staff, most of whom are hired locally. International staff represent just 8% of our total global workforce. Nurses and midwives make up the majority of our healthcare professionals, with over 8,000 nurses globally. Over 70% of care delivered in any healthcare setting is by nurses and by midwives. Nurses in MSF may work in mass vaccination campaigns, in therapeutic feeding centers for malnutrition, in outpatient clinics providing primary health care, or in hospital facilities with specializations, as Odeda had mentioned already, in, for example, infection prevention and control, emergency and intensive care nursing, surgical, pediatrics, oncology, and palliative care. Nurses can fill a variety of roles, from a bedside nurse to a training nurse, from a nurse supervisor of a ward to a nursing activity manager or hospital manager. Nurses also fill coordination roles such as medical team leader of a project, medical coordinator of a country, or as an operational director. As an international organization, we work with teams on the ground. Our experiences will certainly differ to those of our colleagues whose home and family and place of practice has been or is being affected by a disaster. We need to be equally vigilant as volunteers and aware how the context is impacting on our colleagues and the uniqueness of each context that we are in. Nurses are often the only healthcare staff accessible at critical moments. This is especially true for those living in rural areas and in emergencies where the needs are the most. The recent WHO State of the World's Nursing Report estimates that at least 6 million new nursing jobs need to be created by 2030, in which the largest of these needs-based shortages are predominantly in countries where MSF works, in the African and Eastern Mediterranean regions. So to give you an example, comparing the most recent data, in 2019, there were over 300,000 nurses in Australia and over 5 million in the United States. In the Central African Republic, only 322 nurses were recorded with the most recent data in 2015. And in South Sudan, there is no data available. So without even comparing populations, the numbers and the impact is quite significant. There's many contributing factors to this, such as weakened healthcare systems, a lack of educational facilities, access to education, and interruption to education for reasons such as conflict and population movement. The lack of skilled health professionals, and in some cases, the loss of skilled health professionals, creates a vacuum in expertise and an increased urgency to train existing professionals with the needed skills. And when faced with a disaster, these shortages can certainly be compounded. I'm going to hand over to Maria and Corinne now to provide some specific examples on how nurses are affected and contribute. Thanks.
Hello, thank you, Melissa. So as Melissa says, healthcare is complex. Practices are always evolving, and finding well-trained nursing staff becomes a constant struggle in any emergency or disaster situation. So training and building capacity for nursing care is crucial in order to improve the quality of healthcare and to strengthen the local health systems where healthcare human resources are weaker. To ensure we can provide the best quality of care for our patients according to MSF standards and protocols, MSF keep investing in the training and upskilling of health workers, especially nurses, as they are part of the biggest workforce in the organization. Because midwives also are part of this, they are the biggest workforce. Lifelong learning gives nurses the critical thinking and problem-solving skills needed to resolve issues they may encounter while taking care of patients. When nurses are up to date on new techniques, policies, and procedures, we can improve patient safety, decrease mortality rates, and improve patient outcomes. In MSF, nurses' knowledge and practices must adapt to the shifting context we usually work in. This is hard, like wars, famine, or diseases outbreaks. For example, when facing unfamiliar and new epidemics such as Ebola and COVID-19, we need to reinforce the basic of nursing care, adding the implementation of complex, new sometimes, infection prevention and control measures, which often affects directly the daily work of nurses in our field settings. Also, the nature of war injuries and the weapons used nowadays in recent warfare cause massive tissues destruction, increasing the likelihood of infections and the surge of multi-drug resistant organisms, pushing nursing care to be as effective as possible. In conflict settings, nurses may be required to take on additional roles. This may result in nurses working beyond the scope of their training, practicing skills for the first time, or with often limited resources. Conflicts usually affect supply chain, directly affecting nursing care, highly compromising the level of nurses' performance, quality of care sometimes, or sometimes forcing them not to respect essential infection prevention and control basic concepts because of lack of resources. Also, in conflict or war contexts, hospitals have high number of patients coming at the same time, overflowing the structures, affecting significantly the level of nursing care. Time dedicated to each patient is often compromised, and this decrease in the quality of care delivered by the nurses can bring a feeling of frustration within the nursing teams. Limited nursing staff and 24 hours curfew result in longer working hours, despite presenting physical and emotional fatigue. The feeling of being exposed to the risk of violence or attacks can also affect the emotional status of the nursing teams. Concerns and fears are usually not only about themselves or the patients, but they are also about the safety of their loved ones. A hospital is where the most vulnerable, the sick and injured gather in times of war, and attacks against medical facilities and health workers, whether deliberate or indiscriminate, are part of generalized violence and atrocities committed against civilians in armed conflicts. Nurses are there. As a result of these kind of incidents, on several occasions, MSF has had to temporarily suspend medical activities, including providing life-saving care, supervising health center staff, supplying drugs, and transporting patients. These images, the one of the left is an emergency room in Aden, in Yemen, and is one of the largest trauma centers that MSF had. And the right one is Syria following a missile strike, which resulted in 80 being treated in the hospital that day. Mass casualty plan, it is crucial for hospitals in such settings. Training for staff about mass casualty plan to put in place all the resources they need and to practice this plan and triage, as everyone has an important role to play. Mass casualty plan in MSF in Yemen, this is the picture. And when people know exactly what to do facing an extreme situation, can be a high influx of patients after an incident, staff feel more safe performing the roles and tasks. Nurse work will be more organized and effective. In our experiences, we try to implement these trainings in all the settings where we act in conflicts. Like, for example, in Central African Republic, I was in there, we were performing these simulations every 3 months. And also in Yemen, for example, in the north of Yemen. And people, nurses, staff appreciate a lot when we do this simulation because, as I said, they feel more safe at time when they have to work and they know exactly what to do. Next slide. Oh, so I give the word to Corinne. Sorry, no. I will continue talking about the nurses being involved in the community. So MSF nurses are often a part of the community they serve and may have to care for their own family members, friends, or acquaintances. In conflict situations, the lack of security, the sheer scale of loss and destruction, and the chaotic, often frightening situations have a major impact on nursing care. Nurses may have to provide care within or close to active conflict zones, risking injury or death not only while at work, but when traveling to and from work. They may even be called upon to nurse perpetrators of violence or members of hostile forces. In disease outbreaks, there may be the disease of those they are caring for at home. This is something we hear even in high-income countries now in Europe, for example, with COVID-19, and certainly during outbreaks of Ebola, as the one in 2014 in West Africa. We know in some cases this can happen, and the impact this can have on nurses when caring for one of their own is significant. Some may have relocated to contribute to the need, leaving behind their families and their safety. Now, yes, I give the word to Corinne. Thank you.
So this video, I will show you, it's the video was taken in Mayom in South Sudan on the road to the neighboring town. And in this context, providing care might take place in partially collapsed, ill-equipped facility or buildings, makeshift camps or temporary setups, where implemented, maintaining and following good quality IPC standards should remain a priority to avoid spreading infection. It might not be possible practically because of the setting. Tented field hospital can be constructed quickly and nearly anywhere, such as this one after the earthquake in Nepal in 2016. However, they are not without challenges. They are often very hot or cold, lack of spacing for privacy, and additional challenges to provide optimal IPC. This is the IPD post-op care tent in Bangui Community Hospital 2014, where MSF runs emergency surgical activities for victims of clashes and violence in the city. When supply line...
Sorry, Corinne, please can I get you to repeat the content of the access? We didn't hear you because the video was over the top. So just read out the content of it. We don't need to see the video again. Thanks, love.
I will have to go backward. Yes, so the video was taken in Mayom, South Sudan, on the road to the neighboring town. Imagine the logistic involved in transporting the patient and keeping him comfortable and safe in those roads where sometimes it's really hard even for the patient to go through. So then when supply lines are cut, nurses must work with fewer resources, often necessitating rapid on-the-spot assessment and problem solving, including making judgment about what compromise can be made to nursing care with minimal impact on the patient's safety and well-being. At the onset of COVID-19, globally, there was a shortage of essential of PPE and in many contexts, oxygen. The bulk of all our supply comes from European warehouse, making it even more difficult, and international cargo was limited. Supplies can also be affected as disaster hits or warehouse targets in conflict. This image is an MSF supply convoy in Yemen filled with medical supply and crossing the front line into the besieged area of Taiz province, taken in 2015. You can see the logo of MSF on the top of the truck to help visualize that it's a MSF truck and identify it. Sun, water, and sanitation, often in disaster, the basic of clean water may not be available due to contaminated water supply system. For nurses, this impacts upon hand hygiene, assisting patients with activities of daily living and their personal hygiene, the flushing of nasogastric tubes, and the wider issues of cleaning and disinfection of nursing equipment, cooking supplies, and feeding of patients, laundry services with providing clean sheets and work attire. The shortage of electricity is frequent, and alternatives such as generators or solar panels might not be available or were destroyed. Electricity is needed for the running of oxygen concentrators, suction pumps, lighting, sterilization equipment. Waste management is often a challenge. In example, this camp, so in Bangladesh, the camp was came into the bush, and then people used all the wood to build their tent or to use for their cooking. And so finally they end up without having roads, without having a place to be able to empty the latrines. And when the flood of the raining season came through, then all the dirt and the latrine and all the waste were dripping through the mountains. So here is also a way to pump water in the soil to help give water to the community of the camp. And I give the hand to Vicky.
Thank you, Corinne. So the next we were thinking how to explain how to analyze risk and how to be prepared and respond in such different contexts that we work in. The first photo we've got here is an urban area affected by conflict. And the middle photo is a protection of civilian camp in a really rural area. And most contexts are affected by disasters, and increasingly so due to climate change. South Sudan, for example, has recently had its third consecutive year of extreme floods. And in the third photo, you can see the middle protection of civilian camp completely surrounded by water. Next slide. So as well as the wider context, our disaster response varies from place to place according to the level of destruction, the number of people injured, how quickly we as an organization could mobilize. We may already be working nearby, but also knowing that there may be other authorities and other organizations in a country that are already responding. We have these pre-packaged disaster kits, which can include a surgical theatre, obstetrics kit, an inflatable hospital, also power supplies, communication materials, facilities to process water, nutrition. A lot of these kits are stored in warehouses across Europe, East Africa, Central America, and East Asia. So if it is a disaster in those regions, we can try and get the kit there quicker. They're already, in theory, custom cleared and ready to be loaded. Next slide, Corinne. But then how do we respond with differing levels of care to an acute disaster on top of a chronic crisis? And the challenges are many in the humanitarian settings that we work in. Often we're running in a survival mode, in an emergency logic, and we've got an acute disaster on top of a chronic crisis. We've got a really weak coping capacity of an existing healthcare system. In many projects, we directly support a Ministry of Health, and we have the added complexity of to whom standards are you working towards. Another challenge is just the sheer differing levels of existing care. And in the photos here, we have an example of two operating theatres, and they are completely different, as you can see. So when you take into account the poor infrastructure, the poor hospital built environment, as mentioned earlier, healthcare worker shortages and capacity, on top of then the language and cultural barriers, preparing and responding for a disaster in some of the settings we work in is incredibly tough. Next slide, Corinne. For MSF nurses, the technical and the ethical dilemmas, they're a constant feature of everyday life. And although every context we work in is different, there's one recurring issue, is that the nursing needs that confront us are just greater than the resources we have to meet those needs. And it makes it almost impossible to deliver an ideal level of nursing care. And we're acutely aware, as Melissa explained earlier, most of our nursing care is delivered by our locally recruited colleagues, and it's those who share that burden of those technical and ethical dilemmas on a daily basis. We've come to the end of our presentation, and we wanted to thank you for your time and for hosting us this evening. And we just wanted to share we wanted to end the presentation before we go to a Q&A with this short video. So Corinne, I'm going to ask you to press play.
3, 2, 1.
Today, I am a nurse without border. Nous sommes infirmières sans frontières.
اليوم أنا ممرض بلا حدود.
Sou enfermeira sem fronteiras.
Aujourd'hui, je suis infirmière sans frontières.
MSF Guinée-Conakry.
Nous sommes forma atagira imbibe.
I'm a nurse without borders.
Sekarang saya perawat tanpa batas.
Je suis infirmier sans frontières.
We are nurses without borders.
ကျမကတော့နေစည်းမထားတဲ့သူနာပြုမဆန်းခွင့်ဖြစ်ပါတယ်
أنا ممرض بلا حدود.
Ngayon, ako'y Nurse Without Borders.
Vandaag ben ik een verplichtende zonder grenzen.
ഞാൻ പരിമിതികളില്ലാത്ത ഒരു നേഴ്സാണ്.
Today I'm a nurse without borders.
We are nurses without borders.
اليوم احنا ممرضين بلا حدود.
Salut, on porte infirmière sans frontières. Peace.
Di lekena sebati bagai ini sekapara keje patan dan bela jirina.
We are nurses without borders. Hello.
Infirmière sans frontières.
Yes!
Thanks, Corinne. I'm going to hand us back over to Andrew, who's going to take us through the Q&A.
Well, thank you for that presentation. That was really, really insightful, and I'm really glad all the videos came through correctly. So no technology hiccups there. So we are at the point of the presentation where we'll take questions from the remote audience, and we do have a couple here. First, there's a question about whether this is being recorded, and it is indeed being recorded, and we will share the link. It'll be on YouTube on Wadham's channel, and we'll share that link with the remote audience within the next 24 hours or so. We may need to do a bit of editing to the video, but we'll let you know when it's available online. We do have a question here from an audience member asking about getting an assignment with MSF, and this is from Montre Smith. And Montre says, I heard it can be difficult to get an assignment with MSF. Any suggestions and recommendations that can help a nurse who would like to work with MSF? Thank you.
I'm happy to take that one. Well, at the moment, it is a little bit difficult because we do have, fortunately, quite full pools. But yeah, usually as a requirement, we expect kind of 3 to 4+ years of clinical experience, depending on the type of project that you'll be going into. If it was, for example, a head nurse leadership position, we would expect extensive experience at a managerial level. We would want people who have worked in varying contexts, in different cultures, and Yeah. There's quite a few generalist positions. So for that case, we usually quite like emergency department nurses, particularly if they've got exposure to pediatrics. And then in some of our projects, we are looking for nurse specialists. So we're looking for an OT nurse or a neonatal nurse. Every region has a recruiting office. So I suggest just to check out your local recruiting section and apply. Has anybody else got anything to add? Melissa, Maria?
Maybe also sometimes languages. So we require to know some languages, mainly English and French.
Arabic also.
And I think the more varied skills that you have, the better. So, you know, having some experience in emergency, experience in IPC, infection prevention and control, of course, oncology, palliative care, having a little bit of a varied experience certainly makes your profile strong.
ER, ICU also, or OT.
Great. I think that answers the next question that was submitted through the Q&A. We have a comment here from Sean Smith. And Sean says, no particular questions or concerns. Just wanted to convey my appreciation and many thanks for helping us, that is WADM, with the webinar. Sean's one of our board members. So I just wanted to convey his comment there and again, emphasize our appreciation of you taking the time to do the webinar for us today. I'm going to put you on the spot, Odeda. Did you have any questions that you wanted to pose to the panel?
Yes. First of all, thank you for this wonderful sharing this experience, because I think everyone heard the name of MSF, but nobody really familiar with your work. And especially because you are working with such an incredible communities in the world. So one question that I have is, what is the level of knowledge, or if at all you have any skills, and nurses who work with MSF, regarding to cultural diversity? Because you're facing so many people from so many world places, and probably there are some changes in the behavior. And how can you adapt yourself at work to cooperate with the communities that you're taking care of, and to be sensitive enough to their special cultural behavior, and to fit into this community when you come in such an emergency situation and you still need to be part of it?
Give it a stab and then the rest can jump in. The cultural safety and the cultural competency needed to really provide safe, person-centered nursing care, we do very much rely on our locally recruited colleagues. But I do think that that holistic lens is so embedded in nursing and the nursing profession that I think it does come instinctively to many nurses. But you're very, very right. Having the humility to understand that you won't know what that person or that community would want in terms of how and where they may want to die, who they would want with them, how people express pain. It can vary so much depending on gender, even in the same country. Yeah, I think it is so country and context specific, but I do want us to sometimes think that there are things that just join us as humans. And I think privacy and dignity and the power of touch. And I think sometimes we've got to remind ourselves of those things that do join us. I don't think it matters which country or context or culture you come from, but you want privacy at those tender moments with your family. And yeah, perhaps I've answered that question, but I'll hand over to some of the others to chip in.
I would just add that as international staff, when we arrive in a new country, a new project, a new context, that there's as much as we want to hit the ground running, it's really important that we give ourselves some time to adapt to that context, to that project, to that culture, and with our colleagues. You know, our nursing colleagues who we work with in the countries we work with are our biggest resource and are the best asset that we have. You know, they have experience and knowledge in different diseases and different injuries and wounds that we may never have seen before. So really working with as a team and learning from each other is very important, and giving yourself that time to adjust as well.
Thank you for that. We have some more questions coming in, and I will remind everyone, if they do want to ask a question verbally to the panel, we do have that functionality. If you want to raise your hand, we can do that. So I have a question here from Marissa Morales, and Marissa asks, well, it's a three-part question, so I think we'll try to tackle this in a few pieces. The first part is, how is MSF funded? And I know this was mentioned at the beginning of the presentation. If I remember correctly, you said around 85% is through donations. Can you elaborate on that a bit? Is that like small donations, or is there support from governments for MSF, or like foundations? Do you have a sense of how the donations are made up?
Yeah, that's right. So over 85–90% of our funding is from private donors. So, you know, people like you and I, we do have fundraising teams in all of our offices around the world who do work on collecting these private donations. We have a lot of regular donors who contribute regularly, and also a lot of quite large donors as well. So having this independent donations from private donors allows us to be independent in the field. So it does allow us to be able to act quickly and to maintain that neutrality and impartiality in some of the contexts that we work that can be quite complicated.
Okay, and then there's kind of a follow-up to this, same question from Marissa. The question is, how do partners reach out to MSF to request support? And I'm wondering, I'm thinking that's kind of local, and when, how do those connections, how are those made?
Maria, would you like to answer that? How we operationally connect with other actors and organizations when we're in the field?
So generally, what happens sometimes is at capital level, we have a coordination team, and so the different capitals of the different countries where we have projects, and they're normally they're organized different clusters, or depending of the crisis, depending of the needs, and depending if it's epidemics, if it's a conflict, and if WHO is present sometimes, or other important actor or UN actor, clusters are organized where all the actors are involved, different NGOs and UN, and we try to synchronize or organize ourselves to cover the needs of the population that we are assisting. So sometimes one NGO covers Watson needs, and MSF covers primary healthcare, and then other do distribution of NFIs, and yeah, and we try to have as an active and effective communication as possible at yes, a coordination, and also at field level afterwards. Now, at field level, we also try always to communicate with important stakeholders of the community. So it's very important for us to interact with different actors at community level.
This is Odeda. May I ask another question related to this relationship? What is the relationship of MSF with the local authorities, such as the Ministry of Health? Are you having a scheduled meeting with them? Are you sharing your knowledge or whatever collected in the community? Do you share with other local caregivers some part of the work? How does it work with you?
Vicky, maybe you can.
Yes, we do. To answer that question, I think any healthcare provider, which is what MSF is, would interact with everybody that you're either receiving patients from or referring to in that network. We would liaise with outbreak response and investigations. We would always share that information. In that sense, it is often nurses that are the eyes and the ears working in these rural areas, working in these clinics that do see these outbreaks first, and that would get communicated into. I think in those sense, there is the reality that in some of the countries we work in, the health system isn't necessarily functioning. And that's when what Maria was talking about, liaising with the other NGOs and the UN actors. So for myself, for example, as a nurse in a rural area, I would liaise with community elders or community leaders or the school or the local actors in my area, that my line manager above me would liaise more formally, perhaps with the healthcare system and other UN actors at a country level.
And it's important to know that we have a lot of projects where we are just as a support. We are not fully taking in consideration all the aspects of the project, but we liaise, we work with together with the MOH. So it's really, yeah, we are always with the ministry. We can't do anything without the Ministry of Health anyway, with the MOU.
Yeah, I was going to say the same thing, like in practicality. For example, when I worked in hospitals where I was having weekly meetings with the hospital director, or we were having infection and prevention control committees involving MOH staff and MSF staff, and we were all together with the same objectives and enriching ourselves, like we were enriching themselves and they enrich us because they are the experts of the context sometimes. So yeah, this is a very, lots of times, this is a very fluid relationship, and we try to do it as best as we can in that sense.
Great. Just point of clarification, MSF is unable to really operate in any particular country without being invited in by the respective government. Is my understanding of that correct?
Yes. In comparison, I think the world is very different to 50 years ago when MSF was founded, and probably very different when you were founded as well, in terms of negotiating access and collaborating with all of the actors. But yes, we need visas and everything else to get into many of the countries. Our operational colleagues spend a lot of time building up those relationships and those networks within a country. But MSF, it is that reliance on that delivering of healthcare and that tangible thing that communities see, and the output of that and those relationships. And that is also what enables us access to different areas. I'm not sure if anybody else wants to answer that question, but yes, Andrew, we do have to.
I would just add that MSF has been in some countries for years and years and years, and often these stable projects, we're always monitoring the situation for seasonal, when we know there's seasonal outbreaks of malaria, for example. Vicky mentioned the flooding in South Sudan. So having projects, longer term projects in these countries allows us to monitor the situation and respond quite quickly to whatever emergencies might arise.
Sure.
The reality is the context change. And so, yeah, your working relationship with, for example, Ethiopia and Myanmar does change over time, and the types of projects you may have will change over time. Yeah.
Yeah, and also sometimes having long-term project in some countries where the countries next door, we don't have any project, but it gives we have some connection with the countries next door. So then if there is any emergency raising, then we can quickly deploy the project and the work over there.
Okay, we have a couple more questions here, and they're a bit varied here, so I thought these might be useful to try to get through before we come to the top of the hour. There's a question from Patricia Frost, and Patricia says, how would you compare the challenges associated with COVID in resource-rich countries to the resiliency associated with this work? She goes on to say, there's so much burnout and moral injury being discussed in the US in contrast to what realistic approach within the resources available to your work entails.
I think that's a really good question from Patricia. I think certainly within MSF, we've all had a lot of humility and perhaps more understanding of where our locally recruited colleagues come from. Like, they live in that level of insecurity all of the time. So supply chain problems, having to work when you know you don't have enough, perhaps PPE, when you don't have the supply chain and the resources that you need, when your staff shortages, you just know that you're not going to be leaving for over 24 hours and there's going to be no one for you to hand over to. So certainly, and living in that stress day to day, I think certainly that's been an observation for us in MSF. If you enter a country to support your colleagues for a period of time, say 9 months, it's not your day-to-day reality. And so I think it's given us a lot of insight and empathy, more insight and empathy into the mental health burden and the impact that has on our teams who are there all of the time. Anybody else, Maria or Melissa?
And specifically in a conflict zone also, for them, the burden to be there. And
Great, thank you for that insight. We have a question that's going back a little bit to the skills that were sort of the theme at the beginning of the Q&A, and I thought it just might be interesting for some perspective on this. But we have a question from Richards asking, does MS allow for pre-hospital skill sets? Specifically, he references wilderness remote EMTs, for example. Would that kind of skill set or that background be a good fit for MSF?
Melissa, do you want to take that?
Yeah, I don't understand very well the terms. I'm very English, I think. So,
for EMT, it means a paramedic, yeah?
Yeah. Technician.
Yeah, no problem. It's something we're discussing, but certainly jump in, Vicky, Corinne, and Maria. At this point, I don't think that paramedics are a part of the healthcare pool that, we are recruiting. We do recognize the unique skills that paramedics have and how they would be an asset, but at this point, it's not something the organization is recruiting. Just to comment on the wilderness and remote, as Vicky mentioned before, having experience, whether you're a healthcare professional or logistics or human resources, whatever it might be, having that experience in a remote context, a low resource setting is really a huge asset.
Yeah, definitely echo that. When we get CVs Australia, Canada, nurses that are used to working autonomously in remote areas. That's the skill set that we're looking for your healthcare staff and your non-healthcare staff. And I think to follow up a little bit on the question of pre-hospital and emergency paramedics, it's a tricky one because in some countries, some of these profiles or professions aren't recognized. And so to work in a country, it needs to be a qualification recognized by that country. So a registered nurse and a medical doctor is always recognized in all of the countries. And the other issue is, particularly for nursing, MSF, we need to step up a little bit on recognizing more of the nursing specialities, but we do rely on generalist nursing skills. And so a paramedic curriculum might not have the breadth of knowledge that a registered nurse would have. And so that would impact on the number of projects that they could get matched to. So yeah, it's a bit of a complex reason, but it's the same reason for why we don't recruit. Some countries have, for example, medical assistants. Yeah, so for the most part, it's a transferable profession that's recognized in many different countries.
And in those cases, we just employ them as national staff, but not international.
Okay, thank you for clarifying that. So the experience of the remote wilderness, working in low resource environment, austere environment would be a huge asset as far as potential opportunities with MSF, but more from a nursing medicine background, from understanding the response here. So we have a couple more questions here, and we got about 5 minutes, and I think we could probably get through both of them. We have a question here from Justin Bays, and Justin asks, how is working for MSF in the field with patients, local foreign staff, etc., changed you as a professional and as a person?
Well, maybe we could all briefly answer. Corinne, love, do you want to go first?
Yeah, that's a very good question. And I think it changed your life. It changed your way of seeing things. And it opened up also your open-minded. Even going back home, then you can bring back some pushback, I would say. You see things a different way, and you can bring a positive side of all the experience you have gone through. So that's at least my experience. For nothing, I would change that. I would go back to that if I had to live another life.
Well, I think from my professional side, it made me a better nurse. Every mission, it made me a better nurse. I was learning so much from the locally recruited nurses and our teams. They were teaching me so much. And it's, yes, professionally, very important. And also I grew up. I was I got more mature in a lot of thoughts in my head, beliefs, cultural beliefs. I don't know. It's learning. It's a non-stop learning experience for me in all senses, as a person and mainly as a nurse. Yeah.
Melissa.
I agree. Same experiences as Corinne and Maria had said. I think professionally, it's, yeah, definitely makes you a better nurse. You really rely on your basic assessment skills and your basic nursing skills and what you can do without having all of those monitors, and, you know, really building on going back to those basics. So certainly professionally, yeah, a big impact. Personally as well, agree. It completely changes you. I think it also makes you realize how lucky we are in many regards. I always go back to the example of coming back from mission and going to the grocery store and seeing, the whole aisle of options of cheeses and breads and what we have available, and just having that realization, how lucky we really are.
Yeah, same for me. Clinically, so much. And just certainly for me, it pushed me into doing my advanced nurse practitioner qualification to really learn consultations in a systematic way, and life skills and just outlook. Yeah, good question from Justin.
Thank you for sharing those personal insights and with the remote audience. I guess we have maybe time for one last question here. It goes a bit back to skills and working in different countries. It's a question from Patricia, and she asked, can you comment on how you deal with the scope of practice issues associated with different countries? Is that an issue? Do you need an MOU?
Trisha's got some good questions this evening. Yes, every country has slightly different approach to its healthcare workforce and scope of practice. And it's something that we do try and understand and negotiate in a memorandum of understanding, so the MOU. But if we were just to take a nursing lens, there's some there's some countries that, for example, have nurse anaesthetists quite commonly. And again, it's understanding from them, what is that scope? Does it have to be, you can be a nurse anaesthetist, but there needs to be an anaesthetist on call, or it has to be an anaesthetist on that floor, or you can independently do it with no one else there. So I think it's understanding those levels and relying, if you're working on international staff, to really understand their scope of practice and their code of conduct and professional accountabilities in whichever country they're licensed, that they hold their license in. Yep, certainly you will in MSF find yourself really working at the edges of your scope of practice. There are times when there is no one else. I'm not a midwife by background, but a lot of countries around the world, nurses and midwives are dual qualified, and so there may be an expectation. And I would have to be very clear that I can help you in the neonatal ward, but I can't help you in the maternity suite. Yeah, and the same for consultations globally. A lot of primary healthcare is delivered by nurses and midwives, and it would be out of my scope of practice as a British trained nurse to be prescribing, but as a nurse practitioner, it's not, if that makes sense, but that is up to the individual. I hope that answered Patricia's question.
I think so. I think that was quite helpful. Well, we're at the top of the hour here, and we try to keep these to 60 minutes. So I'd like to first thank Odeda, because Odeda organized this. She was the individual who made all the connections here and helped bring this together. So I really want to thank Odeda, because she's also helped organize several other webinars for WADM over the past year or so. So we do really appreciate her using her network of contacts to bring in really high quality presenters and panelists to share their experiences with the remote audience. And I really want to thank our panel today. Maria Teresa, Vicky, Melissa. Melissa got up at 5:30 in the morning to do a test run prior to starting this call. So thank you for getting up early for us, and Corinne for advancing slides, and everyone for sharing your experiences. We really appreciate it. We always rely on people to volunteer their time and expertise to participate in these webinars, and we are always very appreciative of everyone for doing so. So I think with that, we'll sign off here and wish everyone happy holidays and a safe and prosperous 2022, and we'll speak next year.
Yeah, thank you very much, Andrew. because without you, it wouldn't work. So yeah, for all your hard work during this year and the year before. And thank you, you're wonderful, wonderful panelists. It was great listening to you and seeing you, and just wish you all, you and the other participants, a happy New Year and Merry Christmas to those who celebrate it. Thank you.
Thanks a lot to you, all of you.
Thank you.
Thank you.
Thank you. Bye.
Bye-bye. Thank you.